Good morning, good afternoon, good evening, everyone. Bonjour à tous. Welcome to the FP 2020 and Partners webinar, Exploring Digital Platforms for Family Planning during COVID-19. It's great to have you all with us. Thank you so much for giving you an hour or so of your incredibly valuable time, both speakers and participants. And as we are getting started, I just quickly wanted to review a few logistics for today's webinar. Firstly, in addition to the presentation that you can see on the screen right now, you will see a Q&A pod where you can submit questions. Please feel free to add your questions in English or en français. If you experience any technical difficulties, please do use the chat box where you can send a chat to all the attendees or specifically to the meeting hosts. In the event you're unable to reach us or need to use email, you're kicked off the webinar for any reason, please do email ybai@familyplanning2020.org. So the next section will be translated into French in one moment. I will just go through it quickly. Today's webinar and the slides are in English, but there is simultaneous interpretation into French. And so as we move in to the start of the webinar, everyone will need to select a language option. Please look at the bottom of your Zoom screen and locate the globe icon that says interpretation. Please select your preferred language, English or French. If you're choosing French, you can click on mute to mute the original audio if you don't want to hear the English narration in the background. Now, these slides are in English, but we will be sending out the slides in English and translated into French soon after this webinar. Unfortunately, we can't project simultaneously in English and in French through the Zoom platform. If you're on an Android or Apple mobile device, in your meeting controls, tap the three dots and then tap language interpretation. Tap English or French. If you select French, please toggle mute original audio, again, if you don't want to hear the English narration in the background. And the webinar is being recorded. Now, I'm just going to hand over to my colleague Yassine Bai to translate a couple of those critical points in French, so our francophone colleagues know where to go for that translation. Over to you, Yassine.
Bonjour à tous. Regardez en bas de votre écran Zoom et trouvez l'icône de globe terrestre qui indique interprétation. Si vous êtes sur un appareil mobile Android ou Apple, appuyez sur les trois points. Sélectionnez le français. Si vous choisissez le français, vous pouvez couper le son original si vous ne voulez pas entendre la narration en anglais. Merci.
Thanks very much, Yassine. Very good question coming through from Tamar. Yes, indeed. The recording of the webinar, excuse me, sorry. Recording of the webinar will also be shared in addition to the slides in English and French that I just referred to. So with all of our speakers and panelists joining us, great to get us formally started. As we all know, as the health sector sees the sexual and reproductive health landscape change and evolve, we're also seeing the rapid transformation and potential of technology as a critical healthcare tool. And in the decade ahead, the decade to 2030, towards the SDGs, we anticipate a significantly increased reliance on digital solutions. We're already seeing this in response to the COVID-19 pandemic, which makes access to traditional healthcare difficult and for some impossible. And so digital health solutions and platforms can empower patients and serve as an effective bridge to ensure continuity for women and girls in seeking family planning services. And our presenters today will expand upon the many benefits and opportunities digital health platforms provide. And we do very much look forward to your questions, as well as we further seek to understand how these developments may increase access and use of family planning services over the coming years. And so as we move to the next slide, I'm Martyn Smith. the Managing Director at FP 2020. Great to be with all of you, and I will just confirm who our panelists and speakers are for this morning's, or this afternoon's, this evening's webinar. We will hear from Trinity Zan from FHI 360 for an overview of digital health. Trinity's a great expert in this area. We're very lucky to have her with us. We're also very lucky indeed to have Dr. Sara Saeed Quram from Sahat Kahani in Pakistan. Really looking forward to her insights in digital health in the Pakistan context, particularly with the COVID-19 pandemic at the moment. Then we will move to hear from colleagues from DKT International, from the HoneyandBanana channel of communication. We'll hear from Nerdesh Tulada and Maja Kahinde from DKT in Nigeria. And then our final panelist, but by no means least, from Ben Bellows, who's the co-founder of the NIVI project, and we'll be hearing from Ben on their work overall and with particular reference to their work in India and in Kenya. So great thanks for all of our panelists for joining us. So we will have around 10 minutes for each of our panelists. Nirdesh and Maja will speak jointly. So we'll move through into our introduction with Trinity in just 1 moment, and we will move through and have 10 minutes with each. You'll be very encouraged, I think, to see that we'll have this good chunk of time from around 7:45 or so onwards for questions and answers. Do get those questions in the Q&A box, and myself and my colleagues Samantha, Laura, Yassine will make sure all of those get answered either within the webinar itself, we hope, or if not, we will be following up with answers to those immediately afterwards. So without further ado, I'd like to move on to the next slide, and great pleasure to introduce you, Trinity, to the team. And we're really excited for your overview here. I think on the second slide, we have a quick bio of your bio, Trinity, but I'll just allow people to look at the extensive experience you have in this area in your bio, and we thank you very much for joining us. I'll hand over to you, Trinity, for around 10 minutes. Thank you.
Great, thank you, Martyn, and good morning, good afternoon, good evening, everybody. My name is Trinity Zan with FHI 360, and it's a great pleasure to be with you today. Next slide, please. And the next one. Great, so if you're new to digital health, then it can sometimes feel overwhelming, like looking up at the universe of stars and really not knowing where to begin. So I've been asked in the next 10 minutes to give a rapid, basic overview to digital health broadly and to digital health for family planning, which is obviously quite a big challenge, so I can't cover it all. And I won't be speaking specifically to the COVID-19 context, but I'm hopeful that this will provide some framing that will help as you listen to our very experienced subsequent speakers. So next slide, please. To begin, it's always helpful to start out with some definitions. You likely have heard some or all of these words: mHealth, eHealth, digital health, as well as things like ICT for development. So I'm offering a definition that comes from WHO, from the Global Strategy on Digital Health, which is the field of knowledge and practice associated with the development and use of digital technologies to improve health. So that's pretty straightforward, and I like it very much. And essentially, if you think about using any of these devices on the screen for part of your health services or health programs, then you are probably engaged in digital health. So it's as simple as that. Next slide, please. Talking through some of the purposes or uses or functions of digital health can be helpful, as well as the channels. And again, you are quite familiar with many of these, I am sure. And so it's just a quick little overview of how we can think about the use of these for our family planning programs. It's a little bit apples and oranges as we think about functions versus channels, but for the sake of just reminding ourselves, of course, you can use these devices to make and receive calls, so voice calls or some of the automated menus that are called IVR. You can send messages, so those can be through SMS or WhatsApp. You can use these technologies to automate logic flows and decision support. So the best example there is really job aids for providers. And of course, you can use these devices to enter and store and send and share data. And the ways that people are using these, the kind of channels, are through apps on the phones or computers, through websites, through social media, and through chatbots, among others. So again, you are very likely familiar with a lot of these in your daily lives and perhaps your personal lives as well as your professional lives. Next slide, please. So now thinking about kind of the organization of the types of digital health tools, I'm offering three big buckets here. You have those that are really focused on supporting providers and being used by providers, those that are really focused more so on individuals and clients, and then those that are really supportive of the broader health system. So for tools that are provider facing, again, we can think about those that will help a provider provide counseling for family planning, or a job aid to help screen somebody for a particular family planning method, their eligibility. For clients, of course, you can think about it as a wonderful information service, whether that is, again, through the phone or the website or chatbots, as we'll hear from our subsequent speakers. Individuals can also use these devices for kind of personal health tracking and apps, and that's something that's certainly growing in the developed world as well as in our lower and middle income countries. Within the systems, this is much broader for things like managing contraceptive commodities in the logistics management system, as well as things like electronic medical records and registers. But of course, nothing is neat and tidy, so there are certain uses that seem to have overlap across these categories. And again, I think we'll be hearing about some of those later on. In particular, if you think about telehealth, that's an interaction between a provider and a client, so it's not easy to bucket into one of these categories. As well, referrals, providers can use them to make referrals, clients can use them to use those referrals. So again, it's crossing categories, as well as for supervision, remote supportive supervision. That's very much in support of providers, but really a part of the broader health system. So it's helpful to think about it in buckets, but never quite as neat and tidy as we'd like. Next slide, please. So there is quite a bit of both information, evidence, and guidance related to digital health broadly and for family planning specifically. So again, if you're feeling overwhelmed, fear not, there are resources available for you. The WHO in particular has been working in this area for quite some time. And so they have a very useful and very detailed list of classifications of digital health interventions that goes far beyond the three buckets that I presented to you. They've also recently released recommendations for the use of digital interventions in support of health system strengthening, and that is based on very rigorous evidence reviews. And so this goes through quite a few of the digital health interventions that they also identify and is quite useful. They also have guidance for developing e-health and digital health strategies, as well as in the center, a very useful tool for helping countries and partners determine, project, assess the scalability of a given digital health intervention. So these are just a few of the resources available to you. When it comes to family planning specifically, digital health has been incorporated into the High Impact Practices Initiative. So currently there are 2 HIP briefs that focus on digital health. One is more client-facing, so digital health for social and behavior change. And one is currently focused on the broader health systems and how this HIP is an enhancement to the broader health systems. And so again, touches on use in logistics management, in health information systems, as well as in support for providers. And in the near future, we will be having an update to that one with some additional information related to the use of tools by and for providers. So something to stay tuned for. Next slide, please. So just very quickly trying to give you some highlights about what we know based on the evidence about digital for family planning. This is a crowded slide, so apologies for that. But there is indeed evidence that these interventions can support a change in knowledge and attitudes among individuals. We also know from quite a bit of documentation that these interventions are particularly attractive to and for young people. There is mixed evidence about the impact of digital for SBC on behavior change. So they're thinking about contraceptive uptake and continuation. There are definitely promising signs, but there is indeed mixed evidence. So it's an area for continued research. We do have evidence to support increased efficiency, particularly time and accuracy with the use of digital within the system. So thinking again about electronic medical registers, about data collection and logistics management. In some ways, it's sort of a no-brainer that these can make data collection and tracking products quicker and more accurate. We also have an increasing evidence base related to how these digital tools can improve provider knowledge and competency when it comes to being trained on particular counseling and method provision. And we also have very limited and mixed data related to cost. So although we often want to believe that these are more cost effective, and in some cases we have indication that that's true, there's very limited cost data. So that's another big priority for future research generation. Next slide, please. And when it comes to implementation, what are our considerations? Well, there are many, many. I would just direct everybody who's interested to the Principles for Digital Development, which is a set of 9 principles that were developed and arrived at by a broad coalition of donors, implementers, partners. And a few of them are here related to considering the broader context for digital. As you would all know, thoughts about electricity, cell phone coverage and cell phone ownership, the need to make sure systems talk to each other, and the need to look and build upon what exists and not start from scratch. When it comes to family planning in particular, there are, of course, considerations for informed choice, privacy, and confidentiality, as we do in all of our services, that can sometimes be complicated by the use of digital and sometimes enhanced by the use of digital. Quality of care and confidence in interactions. Again, some people are quite comfortable interacting remotely with a provider while others are not, as I'm sure we'll hear more later. And finally, gender dynamics, not just related to use and access of cell phones, but there's actually some evidence that has indicated that digital interventions for FP and RH can have unintended negative consequences related to gender-based violence. Now that's limited, but of course it's something that we always want to be mindful of. So these are just a few of the implementation considerations. That was quite the whirlwind tour, but I have provided some links within the presentation, and I'm happy to answer broad general questions at the end, and really look forward to hearing from the rest of our speakers. So thank you very much.
Thanks, thanks so much, Trinity, for that, that excellent overview. For reminding us that obviously we're talking about provider-facing, client-facing, and systems digital interventions, but they overlap and they come together for highlighting where the evidence stands, and great to know you're working on further high-impact practice briefs in this area. So, and that was it's an excellent introduction and segue, I think, into talking to our next speaker. Next speaker is Dr. Sara Saeed Quram, who's the co-founder and CEO of Sahat Kahani in Pakistan. And we'll just move to your bio, Sara, as I introduce you. And it's great to have you speaking to us about this excellent all-female health provider network, which has been established in Pakistan. We're very interested in your views on digital health, and also either within your presentation or perhaps in the Q&A later to understand how this channel, how this means of interacting with clients, with women is faring during the current COVID-19 pandemic in Pakistan. So over to you, Sarah, for about 10 minutes, and we're really excited to have you online with us, and good evening to you in Pakistan.
Thank you so much, Martyn. I'm really excited to be here. Thank you for making me a part of such an important panel in this time, because I think COVID had really taught us a lot of lessons for a lifetime, and I think telehealth is one of those. And thank you, Trinity, for setting that background, because I think that was extremely important to all of other presenters. If you can have if you can move to the slides, please, I can start giving an introduction about my work at Sahat Kahani. So Sahat Kahani is, and just to give you a background, Sahat means health in Urdu and Kahani means story. So very poetically, we are trying to change the way health stories are written in Pakistan using technology. And it is an organization that is created by me and my co-founder. We are both female doctors. And I think there is something which was very common when we met each other. And that something was that once in our lifetime, we had faced a problem of working after marriage or responsibility. And both of us had struggles to get our self-esteem back as doctors because of that break. And what we realized after talking to each other was majority of our medical workforce in Pakistan is made up of female doctors. So Pakistan has a total medical workforce of 170,000 doctors, and around 70% of more of these doctors are female doctors. But unfortunately, the amount of female doctors that work after marriage or responsibility is only 23%. If you can move to the next slide. And we call this the doctor bride phenomena in Pakistan, that majority of the female doctors between graduation leave and become makers. So women like me who belong to mixed family in Pakistan are not made doctors so that they can serve the community, but they're made doctors that can have a better hand in marriage because it raises the stature of a woman in society. If you can move next slide. But for a country, Pakistan, around 200 million people and above, when majority of your medical workforce sits at home, what happens is 50% of our population does not get access to a qualified doctor in their lifetime, which means they might be going to a quack or midwife, but they don't go to a qualified doctor, and especially a female doctor. And unfortunately, it affects more the vulnerable population in the country, which are women and children. So 37% women still deliver at home. 1 in 5 children do not. If you can move to the next slide, around 200 million people. And what happens is 50% of the population, which means they might be going to a quack or midwife, but they don't go to a qualified. And majority of this affects the low income or rural communities in Pakistan, which is above 60%. Next slide, please. So what Sahat Kahani does is we connect female doctors, patients who need healthcare using telemedicine technology. So we figured that if a patient cannot reach a doctor physically, we can at least make the patient see a doctor virtually. And Sahat Kahani does this through 2 interventions. If you can move to the slide. The next one, please. We do that through 2 interventions. So for low-income communities where people don't have access to smartphones or technology themselves, we create nurse-assisted telemedicine clinics. These clinics were owned previously by nurses who were doing, because of the. But what it does now, the majority of the medical percent of a population does not get access to it as well. So we upgrade these nurses into primary healthcare workers, giving them medical training, and we teach them a. So what Sahat Kahani using telemedicine technology in their community, in that clinic. For people who have access to smartphones and technology in Pakistan, because Pakistan is also a country which is increasing in tele-density, and we have over 75 million internet users now in the country, we have a mobile application that can be downloaded by anyone individually, and anyone can connect to a doctor 24/7 through a chat or a video consultation. And for both our methods of work, we focus a lot on health education and promotion, physically in our clinics and virtually on our mobile application through SMSs, reminders, etc. Next slide, please. So what do we provide in our clinics? We provide access to general physicians, we provide access to specialists, we provide access to mental wellness specialists as well. We record health data of patients both in our clinics and our mobile app, and especially in our communities where our clinics are. This is the space where health data was never recorded before. So we provide a chance to patient to have a digital identity. Both on our clinics as well as in our app, we provide access to value-add services. So there are drips and injections that can be given at the clinic. There can be FP services that can be given at the clinic. We can do ultrasounds for women in the clinic. We can do lab collection, and we can also do tertiary care referral. On the mobile app, we also deliver patients pharmacy and lab at home. Next slide, please. So when a patient walks into a Sahat Kahani clinic, they'll get connected to a nurse. The nurse will then connect to an online doctor. There'll be a prescription that can be printed at the clinic. If a patient cannot be seen through telemedicine, we refer them to a tertiary care center. And there's also a 24/7 helpline available for the patient to access if the clinic is closed. Next slide. And on the mobile application, you can download the application and you can connect to a doctor in 24/7 in less than 3 clicks, in less than a minute. You'll be given a prescription that can become in your mobile phone, and you can also have it emailed to you, and you get follow-up reminders as well. Next slide. So this is just a visual representation where on the left side, you see a nurse doing a telemedicine consultation between a doctor and the patient. And on the right side, you see a patient doing a telemedicine consultation themselves using a mobile application. Next slide, please. So what has been our impact? For our clinical model, we have around 26 clinics across Pakistan. In Sindh, Punjab, and KP, Pakistan has 4 provinces. We have 3 of them. We've done 165,000 consultations till date. 90% of these consultations are done for women and children. 20% of these consultations have been done for reproductive health issues and family planning services. We've done 18 health education projects, and we've impacted over 1 million lives, and around 300,000 lives have been impacted using reproductive or family planning education to different women in the communities. All our clinic workforce is made up of women, whether they're doctors, workers, or nurses in the communities. Moving ahead. Next slide, please. On our app, we've totally impacted around 45,000 people, out of which 35 have been women on our mobile application as well. And we also provide the solution to corporates to get their underprivileged workforce, give access to outpatient solutions through our mobile application. Next slide. Especially in COVID-19, I think telemedicine has taken a new term in Pakistan as well, and where there was a lot of inertia to telemedicine. In the country now, we see a rapid uptake of telemedicine and telehealth services. So Sahat Kahani was able to partner with the government of Pakistan to make our app free for all users for 3 months with respect to COVID-19, training our doctors on COVID-19, screening, triaging, and referring. So we've reached over 1 million people. We've had over 25,000 consultations in the last 2 months for COVID-19 specifically. And we've had consultations from Pakistanis based in the diaspora as well. Moving to the next slide. So we've had consultations from all over the world, from Pakistanis based in diaspora, accessing our application for COVID as well as non-COVID-19 issues for their primary care services. Moving ahead. The total network of doctors that we have is around 1,500 female doctors. We have general physicians, we have specialists, we have a huge network of gynecologists and pediatricians, and we also have mental wellness specialists. And we use these mental wellness specialists, especially in our clinics, at a subsidized rate, so that the communities which cannot access very expensive mental care services in Pakistan can also do that through our clinics as well. Next slide. So I think why we think that we are providing better care is because we're the only female founder-led telemedicine company in Pakistan. We are working cross markets, so we gather data from underserved communities as well as from health underserved markets, but maybe have the power to play. We do extensive outreach activities in our communities, most of which are focused in our communities on reproductive health services for women because they are a primary market there. Moving ahead. These are some partners and supporters that we've worked with. moving forward. So what does Sahat Kahani want to be in the next 10 years? I think we firmly believe in the power of technology and its ability to connect people to one another. So in these last 2 months, we've piloted many projects in which we are seeing the advent of telemedicine. For example, we partnered with the federal government for COVID-19 initiative. We are partnering with lady health workers in the country so that we can provide telemedicine services to women in the communities who now cannot access gynecologists and female doctors due to COVID-19. So we're giving our app to healthcare workers in the province that I'm sitting in Sindh, so that any health worker in the community can then connect the patient to the online doctor and give them access to family planning, gynecologic and reproductive services. We're also using our application to screen positive COVID-19 patients with the help of provincial governments, so that COVID positive patients can get access to a doctor in their home and it does not give additional pressure to the caregivers. So I think in the next 10 years, we see a huge advent of telemedicine in the country. We want to bring back 50,000 female doctors back to work. We want to empower 10,000 health workers through our app in our clinics to provide telemedicine services. We want to make sure that we at least empower 25 million lives through telemedicine, become that telemedicine model in Pakistan that can be scaled to other countries where there are similar problems. But I think the most important point that my company is focusing on is to make healthcare proactive than reactive, is to help women in their pregnancy before they develop complications, is to help a child in their early years using data and analytics so that they don't be malnourished in the later years of their life, to tell a patient with chronic illness that you can develop diabetes in the next 5 or 10 years, so how do you need to maintain yourself? So that's what we are working on, preventive and proactive medicine, so that we can save people from communicable, non-communicable diseases and other primary care diseases in the country, and lead to a healthier Pakistan than we have today. Thank you very much.
Dr. Sara, thank you so much. Inspiring presentation. 3 clicks and one can be in touch with doctor through telemedicine in less than a minute. Amazing statistics in terms of the reach that you've had over the last few years, and testament to the vision that you and your founders have, that you've got this great partnership going with the Federal Ministry of Health in Pakistan to make sure that that information is getting through in this time of COVID-19. So we're getting lots of questions through for you, Dr. Sara. So I'm going to make a note of all of those, and we're going to come back to you extensively, I know, during the Q&A session coming up in just one moment. So we move from Pakistan to Nigeria. And it's great, as I mentioned at the beginning, to welcome Maja Kahinde and Nirdesh Tuladar, who work for DKT International. They're going to talk to us about the Honey and Banana channel that DKT has, digital channel, and we're going to move to their quick bios that are on the next slide, if we can. Great to welcome you both. And we're fascinated to hear your insights in terms of Honey and Banana's work in digital health in Nigeria, and indeed any insights you have in terms of this channel and this work within the COVID-19 context in Nigeria at the moment. Now, I don't know whether I'm handing over to you first, Maja, or to you, Nirdesh. I'm just going to both of you and let you take us through the next 10 minutes. Also, thank you so much.
Good morning, everyone. Good afternoon, good evening.
Hi, Maja. And could your volume just come up just a tiny bit, Maja, if that's okay? Thank you so much.
All right, so good morning, everyone. Good evening, good afternoon. This is Maja Kahinde. I manage the Honey and Banana media. Okay, so the Honey and Banana is a digital ecosystem that comprises of the Honey and Banana social media platforms. Oh, sorry. The next slide, please. Next slide. Okay, so the Honey and Banana is a digital ecosystem that comprises of the Honey and Banana social media platforms the website, as well as the HoneyandBanana Connect call center. This ecosystem is a digital initiative of DKT Nigeria. And DKT Nigeria is a social marketing organization that leverages on the power of technology to provide individuals, especially youth, with access to contraceptive information, services, and products. So why HoneyandBanana? Next slide, please. Okay, so some years ago, a group of youths within the ages of 22 to 27 came together to discuss what kind of services youth would want from an online family planning service. And something stood out of this. The fact that the name is as important as the service and the platform that was going to be used. Why? Yes, youth want this information. They want contraceptive information and services, but they do want it to be private and non-judgmental. So after hours of brainstorming, the name HoneyandBanana came to life. So why HoneyandBanana? HoneyandBanana provides this youth the opportunity to avoid stigma associated with searching for family planning or sex-related information. Also, it affords them the opportunity to have a covert browsing history. This way, when someone comes in contact with their phones, all they think is, oh, she's learning how to make a new smoothie recipe, or she's learning how to mix honey and banana to make a face mask. Also in Nigeria, honey is what a guy would call his lady or girlfriend, and the banana represents the guy. What we know as Honey and Banana today has become a hub where youth get contraceptive information in a fun, youth-friendly, and non-judgmental way. Next slide, please. Next slide. Okay, so HoneyandBanana social media platforms was launched in September 2016. The previous slide. In September 2016, to coincide with the World Contraceptive Day, we have 3 platforms on Facebook, Instagram, and Twitter with the accounts at HoneyandBanana. Also, we have a website. It's quite unique. It doesn't just provide information on contraceptive or relatable stories on sex and pleasures. It goes ahead to link our users with a DKT partner clinic where they can get these contraceptives. Next slide, please. So how do they do this? They do this via the book appointment page. Okay, so the book appointment page allows our website users to do 2 things. Allows them to do 2 things. One, it allows them to book an appointment by requesting for the assistance of a call center agent, while the other way around, they have to search for a clinic themselves. For the book appointment page, they insert their name and their number, and then they get a call back from a call center agent who links them to a proximal clinic. While for the clinic finder here, they have to look through of clinics on the HoneyandBanana website and find a proximal clinic themselves. Next slide. Next slide, please. Okay, so what do we have on the HoneyandBanana platform? What makes up the HoneyandBanana platforms? We have the messaging, our live chat, our referrals, and the HoneyandBanana Connect call center. Our messaging is at the core of what we do. It educates and then it entertains as well. And in the center of our messaging is our TA and the product. Now we have 4 different TA, our target audience. We have the hedonist. This set of people want to have fun, but without consequences. They are 16 to 24. Now we have those that are the conformists. This set of people are sexually active, but don't want friends and families to know about it. They're concerned about their image. And then we have those in the achievement and self-direction group. These people want to reach the peak of their career. They want to make money. They want to get the best cars and live the best life. Then we have those in the security. 80% of them are married. 50% of them are single. This set of people they're all about creating a better life for their family. They want to get the best for their family and also for themselves as well. Now, what is the unique thing about this set of people? They want to achieve all these goals without unplanned pregnancy coming in the way of what they want. So what do? We look at the benefits. We put together the benefit of each of our contraceptives alongside the features of their life and what it is they want to achieve, and let them know that unplanned pregnancy, we can help them remove unplanned pregnancy out of the way by promoting contraceptive use. Then for our live chats, most of the questions that we get from our messaging We pick those that are most frequent or common, and then we create a live chat where we have a medical personnel come and talk to youth about this question, answer these questions as well. Then for the referrals, what we do here is to link our followers to DKT partner clinics where they can get products and services. And then also, we also promote the Honey and Banana Connect call center as an additional option. Here, this helps both our offline audience and our online audience to get contraceptive services. I'm going to hand over to Nedi. She's going to talk more about the Honey and Banana call center, as well as how we've been operating during COVID-19.
Next slide, please. Right, so in addition to the social media platforms of Honey and Banana, we also have the extension as a call center. So in the slides, it says it's Nigeria's first family planning call center. I'm afraid that's not the case. It's actually Nigeria's first digitally integrated call center. So that was a little mistake from our side. Right, so it is a toll-free line and operates with a short code. So, you know, all the users have to do is dial 55059 and it leads to our call center. And again, it provides information on contraceptives, management of side effects, is also able to do clinic referrals. And in addition to all of this, we're able to follow up with our clients. And, you know, one of the best features of this is it's multilingual. So our call agents can, you know, handle calls in 5 major widely spoken languages here in Nigeria, which are English, Igbo, Hausa, Yoruba, and eventually Pidgin. And we feel one of the most unique elements, again, is this provision for a caller to book an appointment with a provider. So you call, you talk, you get your, you know, quick counseling right there. And depending on where you are, you get an appointment straight away. You go to a clinic, you don't really have to wait. And again, these are all done in coordination with DKT partner clinics. Next slide, please. So here, I would briefly like to talk about digital platforms during COVID and, you know, what we're doing now. So as COVID cases starting rising here from February onwards, we updated our messaging on call scripts in the call center, especially to address COVID preventive measures and safety precautions while visiting clinics. And eventually, when the lockdown was enforced here at the end of March, we started changing our messaging to reflect on the current context of the country, the impact it'll have on couples. For example, we began talking about contraception as an essential item needed during the lockdown. The idea, of course, being with more couples staying at home, there's bound to be more sex, hence higher chances of unplanned pregnancies. And considering the uncertain situation, inflation, health risk, you know, the idea and the message we put out both from the call center and also the social media platform was, this is certainly not the best time to have a baby or an extra mouth to feed, as they say here. And from the operations side, I mean, the call center, since the lockdown had to go remote, all of our call agents started working from home. So this did affect our operations in terms of getting the number of calls and returning. But I think one of the most essential things we did for the call center was providing, you know, waiver letters issued by the Federal Ministry of Health here in Nigeria for our referred clients. So someone is referred to a client, but you can't necessarily, you know, walk out of your house during because of the lockdown and the check post and so on. So we got this waiver letter so that a woman can, you know, access the clinics without being harassed in the checkpoints. Next slide, please. Here, I just want to talk about some pre and during COVID insights. Interestingly, for our digital platforms, we got more questions from men as opposed to women who generally call, and questions relating to their partners, adopting a method, you know, and in general, how to prevent pregnancy for my wife or for my girlfriend, that sort of things. And also, we noticed from March to May, the questions started turning more towards emergency contraceptive methods, missed pills, and again, in general, how to prevent pregnancy. And briefly, if you look at our website visits, the graph on the left, bottom left, you will see the websites peaked in April. We like to believe this is perhaps, more people had time, the fact that they're home to access the website, this is what we like to think. But whereas for the call centers, if you look at the slide, the graph, Honey and Banana Connect total calls 2020, it actually went down in March. Again, this is because of our call agents working from home and affecting our operations. Next slide, please. We've been doing this for a while, since 2016. Of course, there are a lot of lessons, a lot of things we've tried, but we sort of felt now when we look back, there are 3 different elements that are very important. So I would say target audience is one. It is very important to understand your target audience, their behaviors, their lifestyles. And eventually, this is what makes you able to connect with them in your messaging, creatives, and so on. The other element we would say is a very strong brand must be built. And what we did with Honey and Banana. You would see a logo of Honey and Banana with 55059 and people immediately know what that is. And I feel this is a very vital point, especially now, because there are so many platforms doing very similar things. And indeed, the branding helps with visibility as well as credibility. And finally, we would say that in addition to all of these platforms, you do need a referral connection. So this sort of completes this whole seamless digital ecosystem. You do have to refer someone, somewhere. And not only that, you have to develop this partnership with the clinics. And once you do that, again, the other element I would say is, you have to do follow-up calls, get back to the callers, ask them how things went. So in short, for us, this is the whole digital ecosystem. With that said, we welcome you to follow us on Honey and Banana. Thank you very much.
Thanks, thanks Nirdes. Thanks, Madza, very much indeed for taking us through the Honey and Banana digital ecosystem. The strength of the brand is very clear in the Nigeria context. Very interesting insights in terms of the COVID-19 situation, the peak in website views that we saw in April during lockdown in several of the states in Nigeria, and this important change that we seem to be seeing in terms of referrals through Honey and Banana to clinics, and that critical point that was made around the strong partnership that needs to be there between the digital platform and those clinics, a strong and an ongoing partnership. So thank you so much for those great insights into Honey and Banana and the context in Nigeria at this time. So we move on to our final speaker and keep those questions coming along. And just to remind you all, we are recording this. You'll get the recording, you'll get the slides in English and French straight after, or soon after, I should say, this webinar is completed. So our final speaker is Ben Bellows, who's the co-founder of Nivi. We'll move to your bio, Ben, and great to have you with us. We're really excited to hear your insights in terms of Nivi's work. Particularly, I know the way that you've pivoted your work in markets and places in India and in Kenya. And be great to hear your insights on COVID, as well as where you see Nivi and the field moving over the next few years. So over to you, Ben, for about 10 minutes, and then we will get into that Q&A. Thanks.
Martin, thank you for that warm welcome, and everyone, it's great to join you today. Thank you for your attention, the opportunity to connect. If we could start with the next slide. Just a bit of background. Nivi is a consumer-facing digital health company, and predicated on this vision that we can support users and help users unlock their own agency and volition in seeking services. And today I want to speak and share a bit about what we've done leveraging our digital platform to address family planning needs in what we're now recognizing as the COVID era. Next slide, please. So first, a bit about the model, and then I'll quickly get into what we've done with COVID. Nivi as a model has essentially a B2C or business to consumer face, as well as a B2B or business to business face. And this model here captures both of those elements. If you'll bear with me, the engage component, beginning on the left there, focuses on the holistic experience of raising awareness on a health topic with consumers, working with them through that initial marketing and onboarding, and bringing them into a series of message-based conversations through popular messaging platforms like Facebook Messenger and WhatsApp, and providing information, actionable information that leads or culminates in some sort of behavior change or a service or a product uptake. So it's predicated on information promoting or catalyzing behavior change in both a nonprofit, for-profit, and public sector sense. So we do this in currently Kenya, India, just opened a campaign in South Africa and looking at Nigeria in Q4. And we do this, we provide that B2C experience, that holistic marketing and information campaigns to behavioral outcomes to, on the B2B side, serve. So NIVI's built to serve others, to integrate into and support the work you're doing. And I think that's an important point to consider to Martyn's lead in here for this panel. We think about what's the value add? What are some of the lessons we can derive from what we are doing collectively here on the panel? And part of this question that we all face, or many of you are facing, is do we build or do we buy at the end of the day? Is there in-house capacity to launch something like what you've heard discussed on the panel, or are you looking for an opportunity to simply subscribe and buy into a service that has the expertise and the ability to deliver services like what you're hearing today? So we've built this and are betting that there's enough demand globally for this sort of service that can generate that engagement and then produce insights for these B2B partners about that engagement. Being able to provide that sort of monitoring, that MLE, the monitoring, evaluation, and learning piece for our partners at a reasonable monthly subscription that generates insights and helps our partners to optimize the targeting, the engagement, the outreach that they're doing already with their target audiences, or tapping into our growing user base in each of the markets that we're operating. So it's all predicated on this sort of optimization iteration cycle and bringing at the core of it the user into this more active state, helping them essentially drive their own care, their own self-care, as in user-initiated care. So at every step of the way, they're opting in, asking questions, learning more, and acting on that new information. So next slide, please. So real quickly, what we've done in India with the onset of COVID, we very quickly in mid to late March made the decision, recognizing COVID is going to be a global challenge, and created COVID-specific conversations. We began getting feedback from partners and the ecosystem in India in particular that the lockdown was creating challenges in accessing family planning and other SRH services. So the data I'm presenting today come from about 4 weeks where we launched what we were calling COVID-19 and FP conversations. These are conversations that explore the challenges of accessing family planning during this COVID lockdown. It's kind of an evolving situation. And in those 4 weeks, we raised conducted marketing outreach. We reached about 12.5 million people with the ad messaging. So we could see from largely Facebook and Google AdWords that we're engaging users with marketing assets like the two examples you see here. It was in English and Hindi. I think about 80% of the users are engaging the platform in Hindi. And we're using different kinds of marketing assets to generate or access different market segments, different consumer segments online. From that very large reach, from that very large series of marketing campaigns, we onboarded in this time period almost 100,000 users into conversations. So we think of NIVI users as those who are accessing or learning from these conversations. We saw that on average, NIVI users are exploring about 2 conversations per user on average. So we had 185,000 conversations around family planning and COVID-19 that were explored. Next slide, please. And you'll see that this onboarding, these are a couple of screenshots from, again, the messaging platform on WhatsApp for the consumer, generating data and insights for us and our partners. And you can see some of the information is coming from actively reported feedback from the users. So they're entering their postal identification number, the PIN code in India, to give us a better idea of where they're coming from within the country. And you can see this top level menu on the left. Type or enter number 1 if you want to go into COVID-19 questions and answers. Type or enter number 2 if you want to explore family planning during COVID, and etc. So you can drill down into these conversations, and we learn a lot about the users as they explore these conversations, right? So the further they go into, say, a given topic or domain, the more intense or more intent they have in that particular topic. So we begin to infer and predict something about our users based on the way in which they're engaging the conversations online. Now, we were also asking on the right about solutions. Are you curious about or interested in consulting a doctor, finding a prescription, or perhaps ordering medicines for home delivery? And so we began to offer users not only an opportunity to explain what their experience under the COVID lockdown was like, but also some of the solutions to problems they may be experiencing in accessing family planning. Next slide, please. So we're able to take that data, and I just wanted to highlight, and this is high level, it's for purposes of discussion, but to highlight both the barriers that our users were reporting. So for those users that did get into this question and this conversation, series of questions and answers, onto whether they were experiencing problems or challenges in seeking family planning at a pharmacy within the past month, half of our users reported not getting the method that they intended to get, to source from these pharmacies. So half did, about 49%, but then others were encountering barriers. They didn't have the prescription available, presumably because the doctor, or they couldn't find the prescription. The method was out of stock when they did get to the facility, or the pharmacy was closed. There are challenges in accessing services on the one hand, and a heightened demand or interest in online services. So again, in that narrow window of 4 weeks, 66% or 2/3 of our users that answered this question were keen to learn about online services. So they're clearly looking for some alternatives. So next slide, please. So what we've done, and some of our initial partners, including PSI in India, is now, in response to that, we have built out and are now running integrated services with pharmacies. We've identified 6 online pharmacies, e-pharmacies, and online consultations. We've asked users to basically which of these they're interested in, what their experience has been with them, if they've had one in the past, bringing these up if this is the first time, presenting them as new information to the users, and basically enabling the users to access family planning for those digital services, including consultations and product sales, for users that otherwise are facing difficulties in accessing care. So that ability to integrate information, to identify problem identification, identify that problem through the conversations, the data we're collecting, and then generate solutions based on their responses and do it quickly, I think is indicative of the power of digital. It's one that's not exclusively NIVI, obviously. I think you're hearing other examples that have done this fairly quickly. And we're doing this in partnership with, or with the explicit objective of, optimizing what our partners on the ground, including PSI IPL, this is the India Private Limited social enterprise entity in India, working with PSI IPL on the ground, and others to integrate e-pharmacy solutions into what they're already doing. So helping our partners, including new partners that we're looking for, and always welcoming on board opportunities to engage their existing user base as well as our existing user base in these sort of solution-oriented conversations. So with that, next slide. I'd be keen to hear questions or ideas people have had, but that's the overall NIVI platform. Thanks, Martyn.
Thanks, thanks so much, Ben. Great stuff. I liked your mention of getting users or potential users into an active state of engagement through the platform. Some sobering stats in terms of the information you've collected during the COVID time. In the India context, half of potential clients reporting they didn't get the method that they wanted. But then this heightened demand for online services and this increased integration that seems to be in a nascent state, and the link-ups that are occurring between digital platforms and e-pharmacies, partners on the ground that you described, very encouraging, and the start of something big, it seems, in several of the markets that you described. So thanks indeed for that, Ben. And so now we move into our Q&A section, and I see that several of our speakers, particularly Dr. Sarah, have been very active in the Q&A chat and the conversation and answering lots of questions from you all in real time. So thanks to all of the speakers and panelists for engaging there. But plenty of questions, and I do hope we can all stick around for a few more minutes to get several of these answered if we can. And a few of them are for particular speakers, and several of them I'll ask for insights, perhaps from 2, 3, or even 4 of our panelists. But we'll just get started on the initial one to bring us back to you, Trinity, if that's okay. You gave our first presentation of this morning, and good question here. What evidence, Trinity, exists for the feasibility and effectiveness of these e-commerce platforms within health, or within sexual and reproductive health? Are there platforms that you're seeing that are feasible and successful? That's the first question. And then a second question also to you, Trinity. Is there evidence on the scalability of digital health solutions for family planning that is adaptable to a country like Uganda? And what key considerations do we need to think about in scaling up? So quick couple of questions for you there, Trinity, and then I'll move on several that I'll then pose to Dr. Sarah.
Sure.
Thanks, Trinity.
Great. So on the e-commerce, to be honest, it's a relatively new area, particularly for family planning. So there are certainly multiple platforms, and I think, Ben introduced a few. I think there are probably far more than we actually even know of at the global level. Some of them are kind of bubbling up to the top, and there's Kasha and Kenya and others. Some groups like Y Labs are working in coordination with those to actually produce evidence about both feasibility, acceptability, and uptake. But I think we're still nascent enough that there's not a lot of documented literature. So you'd have to do quite a bit more of digging and going directly to the source. But there certainly does seem to be some indication of use of those services. On the scalability, of course, it depends on how we are defining scale, but I would say yes, certainly. There are multiple services. Viamo's 321 service has scaled across many countries with a very successful sustainable financial model in collaboration with the mobile network operators. But there are many other examples. Ours from FHI from many years back, one of the first text message information-based services, M4RH, scaled across and within multiple countries, including in Uganda. So there are definitely examples, and the kind of criteria and considerations for scale are available in a number of resources, including in those HIP briefs, if people would like to look within those, and that MAPS toolkit for scaling from WHO. So those would be a couple of places to look for additional information. So I won't go further into detail given the limited time.
Thanks very much, Trinity. I'd invite, if there's one of our other panelists who had anything in follow-on to those two questions about the feasibility, effectiveness of e-commerce platforms within health and family planning, particularly Ben, Sarah, Maja, Nirdesh, any quick comments from any of you on that point?
There are plenty. Trinity's point there are others. There are many platforms out there, yes. And the interesting thing about the e-commerce opportunities is it providing there are different ways to structure e-commerce. It can be product and sales, or it could be insights. And I'm interested to hear if there are examples, or to what extent the analytics has a role in developing essentially knowledge products or an enhanced experience for users. For instance, you could imagine having specific products, physical products that come with an advice line, a helpline, text more to or send a message to this resource. for more of an integrated or an optimized consumer experience that incorporates both the physical product, but also a way to learn more about that product, kind of unlock the extra benefits of that product through messaging and kind of post-service or post-sales support lines.
Thanks very much indeed, Ben. Great. Thanks, Trinity and Ben. So I'm going to move Dr. Sahat to you next, if that's okay. And several great questions for you. Firstly, any evidence on the equity of the impact that Sahat Kahani is having? And a second question here, what percentage of patients using the platform are men, and do they feel comfortable in interacting with female providers? And then a third and final question here, Sarah, for the moment, what challenges have you seen in terms of adolescents and young people accessing digital platforms in the Pakistan context? So over to you, Dr. Sarah.
Yes.
Thanks.
Martyn, can you repeat the first question?
Yeah, no problem. Is there any evidence on the equity of impact? So are you seeing impact in terms of higher income clients in urban areas compared to lower income clients in rural areas and points in between?
Okay, so I think Pakistan is a very unique country where we have around 70% patients being out of pocket, whether they're based in low income, middle income, or high income segments. So the public healthcare system in Pakistan is actually it's a very less proportion of people spending on healthcare. People in low income communities, especially the vulnerable population, the women and children, why they suffer more is because they have additional challenges in accessing healthcare. Even if they have money to spend on a doctor, they don't find a doctor in their communities because doctors don't travel to low-income areas to provide healthcare, specifically female doctor, because of the issue I already explained. Then access to labs, access to pharmacies, access to emergency care services, they have to walk. So for example, some of our clinics are in areas from which the nearest tertiary care hospital is 60 to 70 kilometers away. Now imagine a person who's living in a low-income community, leaving their work for one day, traveling to another area, getting healthcare, getting their healthcare done through a doctor, coming back. How much money are they spending on that one day for one consultation that they would have been able to do through a doctor in their community for maybe 1/20 the price? So when I see that health is underserved in the low-income communities because of access, but I also see health is underserved in Pakistan for even middle and upper middle income areas, for quality of doctors, for accessibility, and for affordability as well. So doctors who are available in majority of the areas might not be affordable for a lot of families. And even if they are, there's always a question of who gets it in the family first. So it's normally the men who get it first and the women who come after. So I do think that health is kind of a cross income bracket problem in Pakistan. Now coming to your second question, which is what challenges that we faced. I think the initial challenge that we faced, and we still face it now, even in our clinics and our mobile application, was the adoption of people to a virtual doctors compared to a physical doctor, which is a very new concept. The second challenge is the digital payments mechanism in Pakistan. In the clinics, we charge cash, but in our mobile app, we have to charge digitally. And because a lot of people don't have access to digital banking systems, we have to go for alternative solutions such as telcos being our partners to provide those payments. So I think that's one thing that's still a challenge. And the third thing is there are a lot of policy gray areas for telemedicine in the country, which makes it harder for providers like us to implement our solutions to the fullest. And now, when I talk about young people accessing healthcare and adolescent people accessing healthcare, I think on the mobile app and even in the clinics, we see that their access is not as great as to someone who might be older. And I think simply because even in the clinics, we see lesser number of adolescent women coming to our clinics because they're not having a guardian or a relative to bring them. And on the mobile app, they simply don't have access to mobile phones until they're very old and afford them themselves. But I think the trends in our clinics with respect to younger people accessing telemedicine, once they do it, I think the greater response that we get is from the younger population who comes at our clinics and even on the mobile app.
Thanks. Thanks very much, Dr. Sarah. I'm going to come to Madhya and Nirdesh with a set of questions in just one moment, but I wanted to invite our other panelists, Ben, Trinity, Nirdesh, Madhya, for any insights they had on the challenges that adolescents and young people face in accessing digital platforms and how those challenges can be mitigated. Interested in any quick follow-on insights you have from what Dr. Sarah just mentioned. Esteemed panelists, speakers, let me know if you'd like to add.
I would just add, this is Trinity, that
Trinity.
while there are unique challenges, there are also kind of unique opportunities, both because of increasingly adolescents' familiarity with and desire to use those channels. And the most important is to do some of that co-design to help address and mitigate the barriers that they face.
Thanks very much. That critical point on co-design, co-creation with adolescents and young people. Very, very good, Trinity. So I'm going to move on. Lots of questions, Madhya, Nirdesh, for you. Great presentation on honey and banana in Nigeria. I'm just going to pose 3 of them to you both now, if that's okay. So firstly, how have you arrived at the sort of audience segmentation in the honey and banana context? Was that based on extensive research, and how have those profiles changed over time? That's one long question there. Secondly, do you have information for same-sex partners through the ecosystem, through the channel, along with positive sexuality messages for same-sex partners? And thirdly, for the moment, if I can just ask, I think you may have covered this in your presentation, but did you see a very significant spike in the call center increase during the COVID lockdown in Nigeria, which happened in certain states, of course? And is that being sustained as we move through May and into June? So 3 quick questions. Madhya, Nirdesh, I'll leave you to arrange among yourselves who wants to answer which of those.
All right. Regarding the audience segmentation, a research was conducted for us by MC Sachet.
Yep, great.
Yeah. So that's what we use, and they guided us on how to go about it. So we're able to segregate our target audience into what they provided us with, based on the study that was carried out.
Thanks, Madhya. Have those profiles changed over time since the inception of the project some 4 years ago? Have you does that audience segmentation, those profiles, does it still hold true?
Okay, not so much has changed. It was just 20. So yeah, we do make room for changes, but not so much has changed. Yeah.
Right. And the second question then on same-sex partners, would yourself or Nirdesh like to answer this one?
All right. For now in Nigeria, same-sex is not legal. It's actually criminal. So we do not promote same-sex on Honey and Banana. But for abortion, however, after letting them know that what we do is provide pregnancy prevention services, we also refer them to WHO certified sites where they can get abortion services.
Thanks, Madhya. And then this last point on what we've seen through the call center over the last few months in terms of
Martyn, I can answer the third question.
Yeah, Dash. Yeah.
So in terms of,
Still there, Nirdesh? Can I just check that everyone can hear me still?
Yep.
Yep, Nirdesh, carry on. Yassine, are you hearing myself but not Nirdesh at the moment?
I'm hearing you, Martyn.
Okay, you can hear me, Ben. Thanks.
Hi, sorry, Martyn, can you hear me?
Yeah, please carry on, Nirdesh. Thanks for bearing with us.
Right. During the lockdown, one of the reasons was, of course, we scaled down our operations in the call center. And the fact that more people were home, we feel they went more digital, towards the digital line, such as hence, higher access of the website rather than the calls.
Mm-hmm.
And,
Thanks.
but that said, if we go back to our CRM now, I mean, I'm sure there are a lot of inbound calls that we'll have to get back to.
Thanks very much indeed, Nirdesh, and great to get those insights. So a couple of quick questions for you, Ben, and then I have one or two that we'll answer as a group, if that's okay. Ben, firstly, how does the license fee sort of structure work in terms of use of Nivi? First question. Yep. Second question is, great platform, but how, Ben, would this work for women in India who don't have a phone or don't speak English? And then third and final question for you on this round, Ben. What's the status of online purchases of contraceptives in India? Is there a challenge, a legal sort of hurdle to be overcome in terms of selling FP products online, and how does that sort of intersect with the work that Nivi's doing? So 3 quick questions for you, Ben.
3 quick questions, yes. Let me take the middle one first. In terms of languages and access to phones generally, there are 400 million WhatsApp and Facebook users in India alone. So it is a big market. It's not universal, but it is one that is indicative of what we're seeing in emerging regions. There are close to 1 billion individuals between the ages of 15 and 35 who currently have a phone line. They have a SIM card or a data access point in low and middle income countries. So that adolescent bulge, that demographic bulge that we hear a lot about is certainly also getting online in a big way. So we look to where the opportunity is. Certainly there are challenges in accessing phones for some segments of the market, but we look to where the opportunity and where the future is, and the future is online. We anticipate more users, and certainly evidence in the past 10 years. Past trends will carry on into the future with more people getting online as costs go down, access improves. So that is something that we're betting on as a company and as a strategy. In terms of other languages, 80% of our users in India are accessing our conversations through Hindi. We want to add additional regional languages so that more users across the country can access this content in languages that are familiar to them. In Kenya, where we also operate, we see about half of our users accessing content in Swahili. And in South Africa, where we just launched, although initially in English, we are expecting to add additional languages over time, the translation is fairly perfunctory. It's a matter of running it through a translator, getting it back translated and up and running on the platform. The logic is the same regardless of the language. The subscription model, I think, is a very important point. And we've spent, as a community of practice here, a significant amount of time developing products, right? Building in-house capacity that might be better spent, specialized in those companies or organizations that have the capability of delivering again and again a reproducible product. So that you, as a family planning, promoting, or social marketing organization, or a public health agency, can focus on your core competencies, which are engaging your target audiences in discussions around family planning to reduce unmet need and help realize informed choice and voluntary access and voluntary uptake of methods. So I think that, thinking about specialization, that build or buy question is an important one to consider. The third question I'm blanking on now, but taking enough time.
Thanks. I think it was about the purchase of products online in the Indian context, Ben.
Yeah, so some of that is, again, specialization. So we link to platforms that are already operational. We find these online pharmacies, e-pharmacies, and online consultation services, vet them, and we're in the process of learning more about that relationship building. But we have established initial linkages and referrals. And again, this is partly a function of who we partner with. So initially, again, with PSI, looking for other partners as well. They have also established relationships with some of these online platforms. And so through this mutual vetting process can essentially shortlist options and then link to those third parties. So it's about specialization, about working well within an ecosystem to build on everybody's strengths. Thank you.
Thanks very much indeed, Ben. So the final couple of questions aimed at all of you, and I hope I can indulge just for a few more minutes. And thanks everyone for staying with us. This relates to a point that Trinity made in her opening. You know, in your opinion, is the digital approach a really cost-effective way of reaching the very poorest women of reproductive age and getting family planning knowledge and access to services out to them? Is it cost-effective, and is there great potential in it for the future? First question, and then second question is, and it's somewhat a little bit related. You know, are you seeing the need sitting behind these digital platforms, the need for a large sort of administration backroom operation to keep all of these going, or is it are you experiencing an ability to have quite a lean backroom staff that that ensures that these digital platforms are operational? So a couple of quick questions as they relate to cost effectiveness and the way that these operations are structured. And I'm going to go to Dr. Sara first on these couple of quick questions, and any reflections you have, Sara.
Yeah, so I'll keep it short because I do want to give space to other panelists as well. But I think very quickly, what we see in Pakistan is a lot of stigma around family planning practices. And we do have a huge cadre of lady health workers, community health workers, midwives that was created from time to time to cater the issue of family planning, which is relatively low in Pakistan, the compliance. But we see a huge stigma in people. And I think that stigma can be only broken if they get qualified doctor counseling in their communities, which is often not possible. So women generally don't reach out to these health workers because of the lack of knowledge of family planning. And I think if we can do that, which is something that we're doing now with a few public sector organizations, that we're providing the mobile app to health workers so that they can connect to an online doctor and provide consultations. Secondly, I think you do not need as many resources to run a digital healthcare operation, but you do need efficiency in operation. So the only thing that the basic thing of digital health operations is how well you're automating your systems, how well you're creating efficiency in processes so that you require lesser people to do the work and more automation to take the workload. So if we can do that, I think both from a cost-effective and operational efficiency perspective, digital healthcare can provide access to a lot more women in a lot more countries.
Thanks very much, Sara. Nirdesh, Maja, anything to add in terms of the cost effectiveness of reaching lower income women with FP services, and then any reflections on the backup operation that supports Honey and Banana in relation to more traditional channels?
It's quite cost effective for digital. You don't need much. And for youth, basically, data is life. Without even going on our platforms, they would always have data. So they don't need much to do so. And for the call center, it's still free. They don't need credit or airtime to call the call center.
Right.
Then, yes, so for the admin, basically what you need is an individual to manage communication, messaging, referrals to clinics, and answering of questions, basically. So you don't need so much for a startup, for instance. You don't need so much to for the admin. And then for the backup, what you would need is a CRM. One person can start like a customer service, not the call center at first. You can start with 2 individuals to manage the CRM. So basically, it's not so, you don't need so much.
Thanks, Maja. Great insights from the Nigeria context to add on to Pakistan. Trinity, Ben, your insights here would be excellent in general terms and also in the NIVI context. So perhaps to you first, Ben, and then we'll come to Trinity last, perhaps with a more general point. Ben?
Sorry, Martin, I just missed that. There was an interruption on my side.
No, that's all right. So we're talking about, you know, whether these platforms do indeed offer, you know, a cheap, cost-effective way of reaching the poorest women of reproductive age. Part one of the question. Part two of the question: are we seeing a need for sort of extensive admin and backroom staff to support these digital operations, or again, is that proving to be, you know, quite a sort of cost-efficient, lean operation that supports Nivi in your context?
Well, at certain scales, it becomes cost-efficient. So I think to the second question first, the idea here is to move away from bespoke, small-scale, limited number of projects with a limited time horizon, and think big. Think big, act big, and in that way, with the volumes generated, you can reduce your fixed costs vis-a-vis your larger opportunity, right? So larger number of users, and by large numbers, I mean millions. I'm thinking hundreds of thousands of monthly active users on a platform can derive enough value for a company to sustain sort of capital investment needed with engineering and kind of market presence. So the idea is that your business doesn't have to, the costs don't have to scale with the business opportunity, with the user base. And at some point, going digital allows for that sort of decoupling of volume from cost. And that's what we've seen in other industries, and I think that's a fair bet to make in this industry as well. Are we reaching low income and marginalized populations? We could ask those questions. There are certainly equitytool.org, for instance, a website that is based on DHS wealth asset measures, could be incorporated into Nivi. We're looking at how we can do that routinely without losing too many users along the way, but we can also infer something about our users based on their behavior on the platform and how they're entering the platform. So in Kenya, we have an SMS channel as well as the digital Facebook and WhatsApp channels. And we have made an assumption that the WhatsApp users, the SMS users are likely to be lower income. And so we have seen that play out. They tend to be younger. They tend to be more rural. And so we've assumed that those are probably more marginalized populations. It's worth following up. We need to investigate that further. But interestingly, when we did ask those SMS users more recently, do they have other channels? Because we onboarded them with SMS, assuming that was their preferred channel. And that was something, again, an assumption we made in the design. When we went back and actually asked them, to Trinity's earlier point about being user-centered in your design, many of them, about 2/3, were using WhatsApp as well. So it is important to ditch the assumptions and really ask your users about what their experience is like.
Thanks very much indeed, Ben. And so we started with you, Trinity. You're going to have the last word on these couple of quick questions in our final couple of minutes. Trinity.
Great. Yeah, well, I think just to zoom out a little bit based on all of the previous speakers' answers, I think to the question of, you know, what are the costs required in the back end, it really depends on the type of service that you're offering. And so I think we had fairly different platforms and services represented here, and those can mean different upfront investments, you know, different fixed costs and different ongoing costs. So it's really hard to kind of make a blanket statement about the resources required. So that's point A. And to the first question, it's similarly difficult to answer for two reasons. A, the diversity of platforms and initiatives, and B, to determine cost effectiveness, we need to have a comparison. And within family planning, frankly, we do not have a huge amount of literature about the costs required to meet the most marginalized. What we do know is that sometimes those costs are higher. You need more resources to reach the hardest to reach. And so if you think about Sarah's example of a woman in a rural community and walking, you know, and all of those costs that are required, including those missed opportunity costs, as well as the resource intensive, you know, mobile outreach services. So I think that there's definitely the potential for these to be more cost effective, but we need more information both about kind of status quo services as well as the cost to run these digital interventions in order to answer that question.
Thanks very much indeed, Trinity, and sincere thanks to yourself, to Sarah, to Maja, Nirdesh, and to Ben for your wonderful presentations and your great answers to what was really a superb set of questions. Very clear that these digital platforms are going to be a critical part of the landscape during our FP response to within COVID-19, but in terms of our our movement, our family planning movement over the next 10 years going to be increasingly a very, very important part of an integrated landscape. So I really do also want to thank all of you who've joined us on today's webinar. Thank you for your engagement and participation, but also thank you for your important work, which continues in challenging contexts all around the world. We do salute all of you in terms of the commitment and the innovation that you're bringing each and every day to obviously the very challenging situations that are being faced. So with that, I'd like to remind everyone that we will be circulating a recording and the English and French versions of the presentation in the coming days. I'd like to urge you all to please stay safe and stay healthy. Thank you for your engagement with FP 2020 and our partners today. And we do look forward to being in close touch with you in the very near future. Have a great rest of your day. Thank you so much.